Yes, David, thank you very much, and thanks to all of you. And I am really delighted to be here and invited by you to come and give this talk. I mean, I have met quite a few of you in a completely different setting, obviously, in the ward or in the clinic. And it's the first time I'm trying to give a talk about a topic, pancreatitis, which I think all of you know more than I do. Because all of you have suffered this and have, obviously, as David was saying before, that, you probably try to get more information about this than I personally do. As you can see, when we are trainees in this unit, we do liver surgery, pancreatic surgery, liver transplants, and pancreatitis obviously is part of what we deal with. But over the years, I have been in this hospital, in this unit, on and off for the past about 4 to 5 years. I came from India to this place, to this hospital 9 years ago, exactly 9 years ago, November 98, and I have been on and off, and I've seen some of you, Pauline, when I was here before, and then I went away, worked in other hospitals, and came back. And when Pauline asked me whether I would like to give a talk to this wonderful group, I felt really honored, and I think what we'll try to do is talk about this subject, which obviously, as I said, you all know very well, but try to bring in something new, something which is happening or may happen in future for treatment of pancreatitis and diabetes related to pancreatitis. I know, David, you said that maybe talk for 30-35 minutes and then take questions, but I don't mind having questions in the middle. I mean, we can, there's no reason why we have to make this very formal. You can stop me and ask me questions anytime. And maybe I'll ask you a few questions, because I realized when I was preparing this talk that this is the first time I've actually prepared a talk for non-medical persons. And it was very different to the way I prepared the talk before. I prepared the slides and I found that the slides contains lots of terms which may be incredibly medical, and I changed them. But then again, if you feel that there is something which you don't understand what I have said in the slide or what I am saying now, just feel free to stop me and ask me. So what we will try to do in this talk is to, first of all, talk a little bit about pancreatitis, just the basics. What is acute pancreatitis? What is chronic pancreatitis? A few sort of very basic facts, and then go to the main part of the talk, which is relation between the diabetes and pancreatitis. And what I'll try to do is to maybe talk about it from two different angles. From the angle of the patients with chronic pancreatitis who develop diabetes, and also from a completely different angle, the diabetics who are in the community, who are being treated mainly by physicians, not by us, who, when you ask them, do you suffer from any chronic illness, they say, oh, I'm a diabetic. How many of them are actually chronic pancreatitis? They are not branded as chronic pancreatitis. And that's an interesting fact I found out while preparing this talk. So I wanted to actually discuss it in sort of two different angles. And what's new? How can we deal with pancreatic diabetes? Now, pancreatitis, we all know what pancreatitis is. It's an inflammation of the pancreas. And I'm sure all of you probably know that there are two distinct varieties. One is obviously what we call acute pancreatitis, which is as the name suggests, it's an acute inflammation of the pancreas. And it usually just comes on like that. There must be some sort of an acute insult to the pancreas, which may be an acute alcoholic binge drinking. It could be a simple procedure that some of you may have had, like what is called ERCP, that can cause pancreatitis. It can be drug induced, it can be various different things. In medical school, we always used to say, there are about 10 different causes of acute pancreatitis, and the last one was scorpion bite. And I don't know, whenever they asked us this question, the only thing I could remember was scorpion bite and nothing else after that. So, so you tend to remember all the unusual causes, but it is very common. It's very common in this part of the world. Usually self-limiting, which is a character of this. Once the acute insult goes and the acute inflammation goes away, theoretically, the pancreas should get back to what its pre-pancreatitis state was. And it is potentially fully reversible. So if you don't get recurrent bouts of acute pancreatitis, then the damage or the change that happens to pancreas is potentially, again theoretically, fully reversible, but you can end up with some residual problems, and it can rarely, however, cause very serious illness, landing patients up in intensive care unit, cause what we call multi-organ failure like renal failure, liver failure, lung problems, and that is less than in 1% of all patients with acute pancreatitis. So it's very rare that you can get a serious illness with acute pancreatitis, but if you get a serious or what we call severe acute pancreatitis, then it can be a very serious disease. And the next is obviously what we are probably more interested in this forum, is chronic pancreatitis, which is obviously chronic inflammation. So it is both of them are inflammation. So the organ is inflamed. But if you look at the organs macroscopically or pathologically, if somehow we could see an organ, see a pancreas which is acutely inflamed and which is chronically inflamed, it will be completely different. So they are two completely different disease entities, and I'll come to it in a second. So it is characterized by progressive pancreatic damage. So the pancreas gets damaged progressively, and it's characterized also by loss of pancreatic tissue. Now, the pancreas, which again we may all know, is made up of two, very roughly speaking, two large parts. One is what we call the exocrine part, or the part which produces the enzymes for digestion, and the other part is the part which produces the what we call the endocrine part, what it produces insulin. Now, these two parts, although it's inside the same organ, it's inside pancreas, they kind of work completely independently. So the exocrine pancreas and endocrine pancreas, if they were not part of the same pancreas, they would have been completely separate entities. They behave in different ways, and they produce obviously different diseases. However, if you have chronic pancreatitis, it causes sort of damage to all pancreatic tissue, which includes both the enzyme producing ones and the insulin producing ones. So you get what we call exocrine, which means the enzyme part of it, as well as endocrine, which means the insulin part of it, deficiency. So you get an exocrine insufficiency and an endocrine insufficiency, which is a characteristic of chronic pancreatitis. Is that clear till now? Okay. Now, I'll try to concentrate a bit more on chronic pancreatitis, because diabetes is a problem mainly of chronic pancreatitis and not acute. And the acute is a completely different sort of a disease process. So we all know, any questions? No. We all know that is perhaps we all know that is the main cause of chronic pancreatitis. And in 70% of the patient, we can trace the cause of chronic pancreatitis to alcohol. Now, that's a very Western concept though. The place where I come from in India, about 70% is not alcohol related. And again, I'll tell you, it's quite fascinating. It's the same disease, although being started by two different things. Gallstones, the reason I've put gallstone here, gallstone very rarely cause chronic pancreatitis, but that's a question I get asked quite often, that can it be because of gallstone? Now, gallstone cause acute pancreatitis. Due to blockage of the common bile duct, it can cause inflammation of the pancreas, which is an acute event, and it behaves just like alcoholic acute pancreatitis. But gallstone very, very rarely cause chronic pancreatitis, although if you take all chronic pancreatic patients, about roughly 20% also have gallstones. Not necessarily the gallstones are causing the pancreatitis in this case. There is this group which in medical term called idiopathic, which means where we don't know what has caused the pancreatitis, and that's about 20%, where we never find the actual cause. Now that's a pretty big group, isn't it? 20% is a big number in whom we can never say what is the cause of pancreatitis. It's important because in this group, I can tell you that you should not drink. But this is a problem. I can't really tell you what has caused the pancreatitis in the first place. So I can't really tell you to take away the actual cause of it. Drugs can cause pancreatitis. Again, drug like gallstone is mainly a cause of acute pancreatitis. This is another one which we get a lot of patients here, especially in Freeman, because it gets being a tertiary referral center, is the hereditary pancreatitis, which is kind of a genetic disorder. Very early onset, you will have a family history, and it's associated with certain genetic mutations which cause these persons to develop pancreatitis. It's either called genetic or hereditary pancreatitis, sometimes called familial pancreatitis as well. Another important entity, autoimmune pancreatitis, where your own immune system is causing inflammation of the pancreas. There are lots of other autoimmune diseases, like you get lots of kidney diseases which are autoimmune, causing renal failure. Works in basically the same sort of a principle. Primary sclerosing cholangitis is a disease which causes inflammation of bile ducts within the liver. It's one of the common causes of non-alcoholic causes of liver transplant in our unit. Now this is quite often associated with pancreatitis as well. The reason I put it in is there's a couple of patients now in Ward 12 who have got primary sclerosing cholangitis, waiting for liver transplant, who has got well-established chronic pancreatitis. Same sort of an insult caused by our own immune system. Congenital problems, pancreas divisum, have we heard about this? The pancreas drains through a single tube into our bowel, the pancreatic duct. However, when in the process of development in the fetus, the pancreatic duct actually develops from two separate ducts. And quite often we find, I wouldn't say quite often, it's about 10% of all population. They don't fuse together, so they are separate even in adulthood. And out of this 10%, that's the 10% of the normal population. That does not mean all of them develop pancreatitis, but they are more prone to develop pancreatitis compared to somebody who's got a normal pancreatic duct. So it could be a congenital anatomical problem causing pancreatitis. Cystic fibrosis is another disease which is associated with chronic pancreatitis. These are rare causes, cholesterol-related problems, thyroid-related problems, and chronic renal failure or uremia can be. But the problem in the literature is nowhere it is very clear whether they actually cause it or it's just an association. They just go together. But if you go through literature, you will find that this is quite often said. The other thing which I wanted to highlight here, unlike in the last slide where I said familial or hereditary pancreatitis, where the genetic mutation causes pancreatitis, there are some mutations or genetic abnormalities that has been recently identified, which are called disease modifiers. They don't really cause chronic pancreatitis, but maybe make you more prone to develop chronic pancreatitis. Now, this is very simple, and it's quite fascinating as well. All smokers don't get lung cancer, do they? So there must be something which makes one person susceptible to it. Have you ever noticed? I mean, you obviously, most of you have suffered from quite severe chronic pancreatitis. If it is alcohol related, very rarely, and I have never seen one, where cirrhosis of liver and chronic pancreatitis goes together. Now, don't you think it's fascinating? It is the same thing which causes cirrhosis and same thing which causes pancreatitis. Very rarely you get both in the same person. So there must be a genetic factor which makes person A more susceptible to develop liver disease secondary to alcohol, and another person develop pancreatic disease secondary to alcohol, and very rarely they happen together. Now, there's not a lot of literature. If you look at even in medical literature, there's not a lot of research on why that happens. A little bit on incidence. That's in the West. It's roughly it's an American figure, 4 per 100,000 population. Similar in UK. Mainly alcohol-related in Western world. In East, as I was telling you, it's nutritional. It happens in very young age, and it's called tropical chronic pancreatitis. Very common in India, where I come from. However, if you do a pancreatic surgery for a patient with tropical chronic pancreatitis from the East and a patient with alcoholic pancreatitis from the West, and look at them under the microscope, they look exactly the same. And that's what is interesting, because it's caused by a completely different etiology, different cause. But the change that happens in pancreas is exactly the same. Again, the same thing, slightly older age group in the West, in the East it's younger. As I said, tropical chronic pancreatitis is a disease of teenagers, 20s at the most. and it's very, very common in southern India. Clinical features, we all know what is the main clinical feature. We all know it's pain. That's what is the main problem here, isn't it? All the others are secondary. You present with pain, but we'll find out later, not everybody presents with pain actually. But that is the main problem of chronic pancreatitis. The next is the enzyme deficiency. That's why we give you loads of prion. And then is the topic of today's discussion, diabetes or endocrine insufficiency. But you can understand that the pathology is it causes destruction of the enzyme producing cells and the what we call islet cells, which produces the insulin. And then all this ultimately leads to nutritional problem, which becomes the final problem which we have to deal with. And unless this one improves, it becomes very difficult to handle a person with chronic pancreatitis as a whole. And there are some complications which some of us have suffered from. Formation of pseudocysts, a collection of fluid, which is like this is a CT scan showing a collection of fluid around this pancreas, which is quite diseased. A lot of very bright white things here, which are calcium deposits. It's a very, very classical feature of chronic pancreatitis on CT scan. You get calcium deposits on the pancreas. Pseudoaneurysms means abnormal dilatation of blood vessels around the pancreas. Can happen with any inflammation anywhere in the body. So the problem is pancreas is surrounded with various important blood vessels. So once you get a chronic inflammation, you can get this dilatation of various blood vessels, causing quite catastrophic bleeding and sometimes. Pancreatic ascites means leakage of pancreatic juice from the pancreas into the generalized abdominal cavity, causing fluid accumulation. Obviously, we have talked about malnutrition. We'll talk about diabetes. Sometimes you can get jaundice because of blockage of the bile duct, because the bile duct passes through the pancreas. Again, same process. Inflammation causes scarring, and the bile duct can become narrow. Now, moving on to today's discussion about diabetes, and as I said, we are going to look at it from two different angles. Our first question is, what is the prevalence of exocrine pancreatic insufficiency or enzyme deficiency in patients who are diabetics? Now, I'm not talking about pancreatitis here. This is a diabetic patient going to the GP or going to a physician or endocrinologist who's looking after his insulin requirement or looking after not necessarily insulin, if it's a tablet control or diet control diabetic. How many of them have got pancreatic problems? And the second thing we're going to look at is diabetes secondary to pancreatic disease, is sometimes called type 3 diabetes. Type 1 diabetes is the one where you're deficient in insulin. Okay, so you have to give insulin to correct your blood sugar level. So either the cells in the pancreas don't produce enough insulin, or there is something in the body which acts against this insulin to make them not work properly. Type 2 diabetes is where the insulin goes to the cell and works by getting attached to certain receptors, and those are deficient. So in type 2, what you've got a normal insulin level, but it doesn't work because where it is supposed to go and work, those receptors or those joints are defective. That's type 2. So they require insulin quite late. So they're more tablet and diet control. And this is a new term. It was not classically said. We used to know type 1 and type 2 before, but it's sometimes say type 3, which is a diabetes secondary to pancreatic disease. So we are also going to look at how frequent that is. Okay. So the first question is prevalence of pancreatic problems in patients with just diabetes. Now, this is a fairly recent study from America. What they tried to do is all the diabetics that come to the door in their endocrine clinic. So this is a physician-led clinic where where patients are not being referred as pancreatics. They tried to test their pancreatic function. Now, if the pancreatic function is deficient, and by pancreatic function I mean their ability to produce enzyme, because they're already diabetics anyway, okay? So we do not know whether their diabetes is due to pancreatic insufficiency. So they're trying to measure the other part of the pancreas to see whether that is deficient or not. And that can be tested by two means, direct or indirect. Direct means is a bit drastic. You have something like an ERCP, and you take the pancreatic juice from the pancreatic duct and measure how much enzyme is being produced. So that's a bit drastic. It's not usually done anymore. Indirect is very easy. Lots of you have had this by fecal elastase level. So you do a stool test, and an enzyme in the stool tells us how much, how much enzyme the pancreas is producing. Now they found that of all the diabetics who are coming through the door, it was half of them had, pancreatic functional insufficiency. Now that is a bit unexpected. You wouldn't have thought that all of them will have some features of pancreatic, exocrine insufficiency. Similarly, even if you do it by indirect function, it's still quite high. And as you would expect, and as I said, type 1 were the ones who need insulin. In them, it's a bit higher. So the incidence of pancreatic dysfunction is nearly 50% in type 1 and over 30% in type 2 diabetes. So that was a bit unexpected. You wouldn't really expect that to happen unless if you would expect them to happen in those who are known pancreatics, but not in those whom you do not know them to be pancreatics. Again, this is a publication from 2003 in Pancreatology, and it was quite an important publication on measuring it by indirect means, just by measuring the stool test, fecal elastase level, and they found that in 323 type 1 diabetes patients, the pancreatic function by elastase level was normal in half, severe insufficiency, so there must be pancreatics if there was severe insufficiency, in 28%, which honestly, before I prepared this talk, I didn't know that we could have that high incidence of pancreatic functional insufficiency in those whom you do not know that they're pancreatic. So they have never had the severe pain. Okay, so they have never been diagnosed with pancreatitis, and obviously it's slightly lower, proportion in type 2. But now, what about the change in appearance in chronic pancreatitis that we see in the pancreas gland, which we see it when we do an operation on you, or you can see it on the CT scan, like what I showed you on that scan, where there was those specks of calcium or white bits in the pancreas. That's a morphological change, diagnostic of chronic pancreatitis. If you've got that in your pancreas, we would say that you have got chronic pancreatitis. Now that was nearly 40%. So that's quite interesting, isn't it? And again, it was more pronounced in type 1. So that kind of summarizes it. So it's a fairly high percentage of patients who are not known pancreatics but are diabetics actually has got pancreatic dysfunction. And the next question is, so is diabetes secondary to pancreatic disease? And again, we are looking at the same population, though we haven't come to the pancreatitis as yet. Is this quite frequent? Now this is quite classical, this is from quite a long time ago, 1961, 1988. The paper said that the incidence is pretty low. It's about 1.5 to 1.15%. And that's what was thought to be diabetes secondary to primary pancreatic disease. Now I put this paper in because Alberti, he was a professor of endocrinology in Newcastle University, isn't it? Now, I don't know, some of you may have, during various hospital stays, been connected to this glucose, potassium and insulin drip. I don't know, have you been connected? This is just to control your blood sugar by the drip without giving you an insulin, especially before surgery. And that regime of drip is called Alberti regime, because he described it, and he's from Newcastle. And that's his idea of how many of the diabetics suffer from chronic pancreatitis. And in the international classification, disease of exocrine pancreas, or in other words, we can say that is the chronic pancreatitis group. That does come in as other specific types. So very low down in the list of importance. Now, if we take this as the definition of chronic pancreatitis, this persisting and progressive change of the enzyme function and the morphology of the pancreas, then you'll see that a significant number of diabetic patients will show not only functional changes, which means low enzyme level, but also changes if you do a scan, like for example I showed that scan, which suggests a chronic pancreatitis. Then I picked up this paper, which has not yet been published. It has been presented, but it's not been published. And this is again from America. They did nearly 2,000 patients in a university hospital who basically again came in with diabetes. And they went back to see how many of them had pancreatic changes. And it's 8%. It's pretty high compared to what we classically used to think, less than 1%. And out of this 8%, again, this is expected, isn't it? 76% are chronic pancreatitis. So this is pancreatitis-related diabetes. Now, that is something which I wasn't aware of, that if you just randomly pick up diabetics, you can actually find that many chronic pancreatitis who actually didn't have any symptoms of chronic pancreatitis, which is mainly pain. So, is diabetes secondary to pancreatic disease a frequent phenomenon? Obviously it is. It is a frequent phenomenon. And if you, as I showed you, if you look at the type 3 diabetes, it is 8% is a significant figure, isn't it? Now this is the group which we, as surgeons, we deal with, isn't it? This is the ones which come to us, not to the physicians. It's the patients whom we know has got chronic pancreatitis and then they develop diabetes. Now, the prevalence of diabetes in patients with known chronic pancreatitis. Now, even after an acute pancreatitis, which is, as I said in the beginning, is supposed to be self-limiting, completely reversible, during the attack, when the pancreas is acutely inflamed, about 50% have impaired glucose tolerance. So they have got problems with handling glucose. And out of them, about 1 to 5% continue to be, in the long term, become diabetic. However, obviously the figure is much more dramatic in chronic pancreatitis, who have got chronic and persistent damage to pancreatic cells. Now, what is the problem with pancreatitis and diabetes? And those who have got established chronic pancreatitis, the problem is, and this some of you may know, that the part of the pancreas which produces insulin, as I said, they're called the islet cells. They've got two types of cells, alpha cells and beta cells. It's the beta cells which produce insulin. Now they also have got another hormone called glucagon produced by the alpha cell. Now it's a pretty insignificant, it's not a very sort of posh hormone. Nobody really knows about it. However, it works just opposite insulin. The actions are diametrically opposite to what insulin. The importance of it is useful in the fine-tuning of blood sugar. Okay, so if my sugar suddenly decides to go high, for whatever, I may have a Mars bar, the pancreas will immediately start producing more insulin. But it runs the risk of my sugar suddenly going low because there will be a surge of insulin. But what happens is there is a surge of insulin as well as a surge of glucagon, which acts just opposite insulin. So what happens is that my sugar gets controlled in a sort of fine fashion rather than having sudden rise and fall of blood sugar. So that's the work of glucagon. It's incredibly important in maintaining the blood sugar properly. Now, in a chronic pancreatitis, we don't have either of these two working properly. So as a result of that, what happens is what is sometimes mentioned as brittle diabetes. So it becomes very difficult to handle the blood sugar. If I give insulin in a chronic pancreatitis, if I don't give a right dose, suddenly the blood sugar comes plummeting down, and that can cause a lot of problems. So that is the main problem of having diabetes with chronic pancreatitis. It's very difficult to handle it, especially if you're under stress. Especially suppose I'm doing an operation on somebody with chronic pancreatitis. It's incredibly difficult to handle the blood sugar then. And I have said this to maybe I've said this to lots of people in the clinic. It is always a bit better to have the blood sugar high. Okay. Now, what happens again is because of this, because it becomes difficult to handle a low sugar in chronic pancreatitis. So I wouldn't worry too much about if the blood sugar, if you're handling it yourself, stays slightly on the higher side of normal, or slightly above normal. If it is low, it's much more difficult than if it is at high. The complications of blood sugar abnormality is more dangerous in low sugar, obviously, than in high sugar. Okay. Now, quickly going on to something new. Now, has any one of you read about? Yes. Yeah.
Just go back a bit there.
Yeah, sure.
You're saying be high rather than low.
Mm.
I know the low is like you're having a hypos, that's not good. That happens instantly type of thing. But am I right in thinking if you run with too high blood sugar over, I don't know, 10 years or whatever, that's when you can start to get things happening to your extremities?
That's very true. The problems of being diabetic, or the long-term problems like effect on blood vessels of the legs and arms, effect on blood vessels of kidneys, we say that the overall long-term complications of diabetes, if we take chronic pancreatitis away from it, is more if your blood sugar level is not controlled strictly. So what we call strict glycemic control reduces your long-term complication risk. But if you are chronic pancreatitic or having diabetes, because the risk of hypo can be quite dangerous, so we tend to say that it is much better for you to be slightly on the higher side of normal. What I don't want you to go back with the message that you should run high. You shouldn't run high, but you should run the higher part of normal rather than the lower side of normal, because it's much easier for your body to handle higher sugar, because you have got more control over it. You can handle the insulin, but you can't handle the glucagon, because that's deficient as well. Okay, so yes, definitely strict glycemic control improves your long-term outcome as far as the long-term problems of diabetes is concerned. But in chronic pancreatitis, we tend to be a bit towards the high side. You'll notice when we do any operation on chronic pancreatitis, we always tend to keep the sugar high, because it's much better that way than going on a hypo. A hypo is you could say this way: a hypo is handled by a non-pancreatic better than by pancreatic. Okay. Now, I'll just touch on something. Has anybody heard about this islet autotransplantation?
Yeah.
From Canada?
Yes, and also from Minnesota.
Yeah.
There's a place closer to home which does it as well, called Leicester. This is a paper from Leicester. The reason I brought this up is that me being a surgeon, I tried to look at something new that's happening in surgery. Now, I don't want you to go back and say that all of us should get islet cell autotransplant. This is still very new. But it is something which I think is very promising, and that's why I wanted to bring it here today. And you will notice that, and I mentioned it to you, David, that Steve White is the first author of this paper from Leicester, and he has done a lot of work on it. Now, I was telling you that the cells which produce the insulin is the islet cells within the pancreas. Now, the logic behind islet cell transplantation is very simple. If I can take the islet cell out of the pancreas and remove the pancreas away, that will take away the chronic pancreatic organ. And if I can put the islet cell back in you, then potentially that should produce the insulin, so you won't be diabetic. Now, that all sounds very fancy, but there are a few problems here. First of all, how we take the islet cell out of the pancreas, and secondly, where do we put it? It's not like sort of a kidney or a liver or a pancreas transplant where you're taking a whole organ. Now, in chronic pancreatitis, putting another pancreas in doesn't make much of sense. Okay, because in chronic pancreatitis, you're doing the operation, and I have said this several times to all the patients I see, is principally for pain. Okay, the surgery is directed towards pain relief. The surgery does not improve your pancreatic function. But you would, obviously, if you could get rid of the diabetes, that would improve your long-term outcome, isn't it? So that's the idea behind this human islet cell transplantation, which was, I think the major work has been done by a guy called Dr. Sutherland in Minnesota. And they have got the largest published series now on islet cell transplantation. And there's another paper which is also this one, which is again, you see Steve is part of that group. Leicester perhaps has the maximum experience in UK.
It's been funded by Diabetes UK,
yes.
Not the National Health.
Yes. Now, this is from some time ago. Okay, this is from 1998. The reason I put this in is, as you can see, Minneapolis has done, at that time already by 1998 had done more than 50, and Leicester was second largest center at that time. Now, the reason I took this table out of the paper is that first of all, it's a very complex procedure in the sense that you're going to have your whole pancreas removed. Now, you can argue that, what's the benefit of doing that? And there is a problem there, because those of you who have had surgery for chronic pancreatitis, we always say that the pain relief, we can sort of predict that about 70 to 80% get good pain relief, but it is not 100%, isn't it? So there is a 20% people who might not get good pain relief. So I will take the risk of having a major operation where I know that there is a 20% chance that I might not be better. So it is not something which should be taken lightly, and you should go and get your pancreas removed, because the pain might not go away. You might not be diabetic, but you still have the pain. That's not a good idea. Now, the other important thing here, even at that stage, and now this place has done more than 200 of this. Can you see insulin independent for more than 7 days is 69%. So that means 30% was needed insulin even at 7 days. And insulin independent for more than 1 year was about 50%. So it doesn't work straight away in 30% patients. Okay, so what is important is you put the islet cells back into you. It has to be put at an appropriate place, and it must work. That cell must work in a different location. The way it is done is that the whole pancreas is taken out, then the pancreas is sent off to the lab while you are in theatre, and they digest the cells which produce the enzyme, and leaving behind the cells which produce the insulin. And that cells are purified, and then we inject it into a vein which takes it into the liver. So it gets, because the liver is like a filter, it stops in the liver and it stays there, and then it grows a bit and then produces insulin. So there is a fairly high failure rate still, and this has not dramatically improved even today. So it is something which there's a lot of research going on this to try and improve the insulin independence after autotransplantation of islet cell. It's transplantation, but you're creating back your own islet cell, so there is no risk of rejection. It's a question of finding a good place for the cells to go and start working. The problems are, as I said, that it is a big operation, and whether you should take the risk of that surgery or not. And we rarely advise total pancreatectomy for chronic pancreatitis, isn't it? Normally we would do a drainage procedure of some sort, like some of you may have had Frey's procedure done. It's a very common drainage procedure, where we drain the pancreatic duct, and that provides fairly good pain relief. And you can say that I'm quite happy taking my insulin and getting pain relief from a procedure which has got a lower risk than having your whole pancreas removed, because it is a difficult operation. Second thing, as I have said, is independence from insulin is not yet very encouraging. Okay? And the third thing, which is very important, we should not go away from the fact that surgery is for pain relief still. Your surgery is not directed towards getting your diabetes better. Okay? And that's the problem of taking islet cells out of your pancreas, because we tend to do an operation when your disease is so much progressed that you're having intractable pain. So your pancreas is quite a lot damaged. So that must have damaged your islet cells as well. So the yield, or the amount of islet cells you can get out of the pancreas may not be very good, and that's why the insulin independence is not very good. So what the Americans are doing nowadays, and that may become a norm in future, is they tend to do this operation slightly early on. So trying to strike a balance between pain relief and trying to get a pancreas which still has got a lot of islet cells left behind, so that it works. So that is still a bit dodgy as to when one should do this. But again, as I said, this is something from the surgeon's point of view has come in as a new thing in treatment of chronic pancreatitis as a whole surgically.
Can I just ask you then, aren't there also big disadvantages from the exocrine point of view of removing the
whole pancreas?
The whole pancreas. Surely that's going to set up enzyme deficiency.
Yeah, but I mean, again, you're doing an operation when most patients will be enzyme dependent because of chronic pancreatitis.
already.
Yeah. So it doesn't make a huge amount of difference. Okay. Now, if somebody is dependent on enzyme plus is dependent on a huge dose of insulin with his pancreas intact, then you would expect that his islet cell volume isn't great. Okay, so in that person, an islet cell autotransplantation is quite likely to be unsuccessful. Isn't it? So that's the problem with this procedure. Like any procedure in chronic pancreatitis, you have to choose it. You have to sort of tailor it to the particular person you're treating. So this is the message I want to get it across, is that this is a new surgical treatment of diabetes related to pancreatitis. Yeah.
Can you only have the islet transplant from your own islets, or can you get it?
Yeah, you can get it from you can get it from, say for example, like the way we get kidneys and livers from cadaveric donation, but there you're running the risk of rejection. You see, here if you can get it out of your own pancreas, then that is the most ideal situation. Okay, you would not like to run the risk of having some islet cells injected into your system from a cadaveric donor, and you have a major complication from rejection. Plus you have got your old pancreas back, which causes pain. So that will become a bit, obviously unsatisfactory situation. So it's interesting. It's a new thing. It's something for you to go home and think about. And there's a lot of research going on. I don't think it's going to become a sort of norm very quickly. But there is a lot of experience coming up from different centers in the world. And I'm sure in future, if this can be improved somehow, the insulin independence from after following an autotransplantation, then we are going to do more and more total pancreatectomy for chronic pancreatitis. Now, there is some reports again from Minnesota, because they have got such a big series, that even if they don't become completely insulin independent, their diabetic control with insulin actually improves if you do this autotransplantation. But again, that's a bit, still very early days yet. But I thought I'll just talk about this a little bit, because this is perhaps the only sort of very exciting new thing happening surgically for treatment of chronic pancreatitis. Drainage procedures have been there for ages, and drainage procedures don't do anything to the function. This is the only way you can actually preserve part of the pancreatic function by doing an operation. So I'd like to conclude now. Obviously we know that it is a difficult problem, and it's a difficult problem because primarily of the lack of two hormones together and not for insulin deficiency alone. Type 1 diabetic who has got only insulin deficiency, it's quite easy to handle. It's the deficiency of two hormones which makes diabetic secondary to pancreatitis so difficult. It still is predominantly medical, no doubt about it. It is treated with insulin and it's still treated by our endocrinological colleagues. But I think, as I said, in future, surgical treatment will become important, and we will try to pick and choose patients who can be treated with this, and it's something which you should wait for. And the most important thing, till then you should avoid the surgery. Surgery for chronic pancreatitis is not indicated till you are doing it for pain, and it's still the case. Okay? Thank you very much.
A moment for more questions, if you have them.
Yeah.
We had a little nerve person that can't take doesn't drink, treats. Why did you get a new transplant?
Yeah. Well, pancreatic resection, like what you have had at Whipple's, it is something which we have moved away from. The main reason is, if you look at the pancreas organ as a whole, it very rarely involves only one part of the gland. It is usually a kind of a global disease. It involves the whole gland. However, it can involve part of the gland in different degrees. So you can have a disease predominantly of the head of pancreas, disease predominantly of the tail of pancreas. If you have that kind of a situation, then previously we used to do some sort of a pancreatic resection like Whipple's quite frequently. And then there were loads of reports came out from large centers that the pain relief, although initially may be very good, tends to become a problem in long term. Because for somebody like you, who obviously, for 15 years down the line, the rest of the pancreas now is obviously not necessarily is progressing because you don't drink anymore, but it may have been inflamed at that time, and the pain from chronic pancreatitis is mainly nerve related because it's nerves going through the pancreas which gets more and more inflamed with time and causes pain. So it is probably you have got some degree of persistent disease in the rest of the pancreas which is left behind. Now that's the other thing which I found when I looked at the total pancreatectomy for these group of patients who were having auto transplantation. Are the patients like you who have had some kind of a previous surgery and have got recurrence of symptoms. And that is where there's the role of taking the whole of the pancreas out, because we very rarely tend to take the whole pancreas out as a first procedure. Because obviously we obviously don't want to do that, because at the end of the day we do not know how much of the remaining pancreas that you've got still has got some function left. Isn't it? So it is most of the time recurrence of pain is due to persistence of the process of inflammation, and there's absolutely nothing you can do about it. Okay, all you can do, which you have done correctly, is like, because you don't drink anymore, it is probably not progressing at a rate which it would have progressed if you had drank. But as to the rate of the progress is concerned, there is very little else you can do. There is no medication by which you can kind of slow down the inflammation and things like that, which is obviously a problem of chronic pancreatitis. Yeah.
I've had my pancreas removed, and when I go to the diabetic clinic, depending on who I speak to, they'll either say I've got diabetes 1 or others will say I've got diabetes 2. I just want to know which.
You can go and say you've got three now. That's exactly what the classification has now become. The type 1 diabetes is whether if you have got a primary deficiency of the beta cells in your islet, which doesn't produce insulin, or you've got an autoimmune system where your body works against these beta cells. So that's type 1. Type 2 is when you have got a normal functioning pancreas and your pancreas, what we call an end organ defect. So the insulin goes to the cells and then doesn't work because the cells don't work properly. And if it's a primary pancreatic disease or absence of pancreas, then it is classed as type 3 now. Right. So yes, there you go. New diagnosis.
Okay, it's here first.
Any more questions? So as I was telling you, David, that if you want to, I didn't really want to go into the details of how this is done, and how Steve might be quite keen to come and have a chat in one of these evenings and
yes,
how the procedure is done.
I think you've suggested a next speaker.
It will be good because it can follow on from.
That would be helpful, wouldn't it?
Because it's something new. I mean, Newcastle obviously doesn't do it, but you never know. 5 years down the line,
yes,
we would probably take this up.
But then 15 years back along the line, all sorts of things were done which are done today, and which have saved many of our lives.
Absolutely. So I think it might be interesting to have a bit of a details on. Obviously I do not have personal experience of actually doing the procedure of, we have done total pancreatectomy, but we have just not put, islet cell back again. So how the process is done, it's quite a labor intensive thing because it takes quite a while during the operating session to actually extract the cells and put it back again.
And that must make for a much longer operation.
Oh yes, definitely. Yeah. So, but we are used to long operations.
Yes, I know. John has a question.
I could understand a little bit long. I couldn't understand how it took so long to diagnose diabetes. It seems I've had the whole 20 years, yet I put up with it, didn't know what was wrong. And I've got neuropathy, which is 20-year-old now, Yet I've only been diagnosed about 7 months. And I've got all the things, I'm attending 9 clinics.
Yeah, but I mean, where you being, your blood sugar is being checked and things like that?
Well, it hadn't been 7 months ago.
Yeah, I mean, that is something which I mean, ideally should not happen.
No.
Because you see what we tend to do, and again, in patients whom we know have got chronic pancreatitis, what has become a protocol in our clinic, and there used to be a chronic pancreatitis clinic before, which doesn't happen anymore. When I was a research fellow here, it used to happen. Is to check for HbA1c. I don't know whether you know about that. It's a specific type of hemoglobin that we look for in the blood, which is not your blood sugar level, but it's the sugar attached to your hemoglobin, right? And what it tells us is what your blood sugar levels have been over the last few months. If it is stable, then this level is normal. If it has been erratic, then this HbA1c level becomes abnormal. So it's a kind of a screening tool that we use now to check for somebody like you who has the potential of becoming diabetic.
Really, it was only by accident I found this. I'm 68, I had a flu job. And they said, oh yeah, come and get a flu job. Where I was at with blood pressure, 178, and I felt no different at all. 178 and 158, didn't feel any different. And I still don't feel, I'm still in denial of being a diabetic. I don't feel any different. I don't get tired. I do get eyes bleed and then things, this neuropathy. But other than that, I'm on medication, but hardly for me. I don't get tired, which is odd.
I mean, depending on, is your blood sugar level, fairly under control?
Seems to be now,
yes. With insulin, is that right? Yeah.
No, type 2.
Type 2.
Type 2.
Yeah. Well, yeah. The thing is, like all diseases in medicine, the symptoms can be very variable, isn't it? You've got some classical symptoms of diabetes, but it doesn't necessarily happen in everybody. It's a bit odd for you to have established neuropathy.
Yeah, got it quite a lot.
Yeah. Without actually having any symptoms. That is not very common. I must say. Yeah. It is not very common at all, because you would get symptoms of diabetes before you start developing neuropathy, because that's a long-term kind of problem with diabetes. But you probably have had erratic blood sugar before without having any symptoms, unfortunately.
I don't feel any difference. It seems odd. And I don't feel any difference when blood pressure was sky high.
No, that's obviously good in the sense that you feel well, but there's always a worry that you don't seem to get too much of a symptom from.
But it's odd. I can see now how I understand how it's hard to diagnose it, or how to rope people in.
Yeah. But I mean, for us who treat patients with chronic pancreatitis, we obviously go looking for it, because we know that obviously the incidence of diabetes in them is much higher than the normal population.
Yeah.
So if you are a chronic pancreatitic and you keep coming back to us in the clinic, I'll keep checking your HbA1c. And there's something new which some of you may not know. What we have done is we used to see every patient with chronic pancreatitis every year. Now that is, there has been some studies. It's actually no point, provided they are stable, symptom-wise. However, what we have now done is a little pro forma for all GP surgery, which we have distributed, and we send it with the letter to the GP all the time. Is that if this is a person who has got established chronic pancreatitis, once every year they should have these bloods done, and that includes that HbA1c. And there's a clear instruction to the primary care that the HbA1c level must be checked once every year in somebody in whom there is a chronic pancreatitis diagnosis.
Is that not done by the diabetic centres?
Yes.
When mine keeps going up and down, I am type 1 diabetic.
Yeah.
I had no symptoms whatsoever. But my blood sugars go up and down all the time.
Absolutely. I mean, that's what I was telling you, that your symptoms can be so variable, and even when you are having fluctuation, you may not have that kind of awareness.
I can go from 20 down to 3 within a couple of hours.
Yes. I mean, that is what classically is called brittle diabetes. You see, it fluctuates, and it fluctuates because your fine control is not there. And the fine control is entirely because of the interplay of the two hormones. And that's what is the classic happens in pancreatic disease, is that it becomes completely erratic. And I think that is the main challenge for our physician colleagues in handling diabetes for patients who've got chronic pancreatitis. Now, even if this islet cell transplantation doesn't take make you completely insulin independent, if your diabetic control becomes much more manageable, then that's useful. However, it is a big procedure to handle. Yeah.
I have acute pancreatitis. Should I be keeping an eye on my sugar intake, or?
Well, not
what the clinics actually said to do.
Not necessarily, but if you have had acute pancreatitis, have you had recurrent?
Yes.
Yes. I would treat you from the blood sugar point of view exactly like a chronic pancreatitis in doing an HbA1c once every year. And you can ask your GP to do that, or if you come to any one of our clinics, during a letter nowadays we tend to send this pro forma to every GP, saying that this has to be checked once every year, because obviously we would like not. I must say, 70% become diabetic, chronic pancreatitis, and acute pancreatitis, as I said, after a single episode of acute pancreatitis, about 5%, up to 5% can become diabetic. Now, we do not know who's going to become, isn't it? And even in a chronic pancreatitis group, there is 30% who will never become diabetic. So it is useful to look for, it can be done during any simple, blood
yes,
test.
but what I mean is, should I watch how much sugar I actually take in?
Well, there is no evidence that is going to change anything, you see.
All right.
Okay? Because if you are, what I'm trying to say is that if you are destined not to become diabetic, then you are depriving yourself of the sugar. So you should not really,
It's just when you buy stuff.